A very good day to everybody. Welcome all of you to another academic hour brought to you by the GMOA Academic Subcommittee. So firstly, let me introduce our presenter. She is none other than Dr. Paula Quigley, who is a medical doctor from Ireland with over 35 years of experience working overseas in health program management, monitoring and evaluation, and health system strengthening. She specializes in reproductive, maternal, newborn, child and adolescent health and nutrition. She has worked mainly in South and Southeast Asia and Sub-Saharan Africa. Currently, she works with DAI Global Health, an international development organization, and leads the Technical Assistance Facility on Nutrition Action for Systemic Change, also known as NASC, in support of the Foreign, Commonwealth and Development Office of the UK government. She is also the chair of the International Stillbirth Alliance. So I kindly request our learned audience to type in your questions while the lecture is going on, as we are expecting a Q&A session at the end of the lecture. Without further ado, Dr. Paula Quigley, this is my invitation to you to start the presentation for today, Global Maternal, Newborn and Child Health Implications for Sri Lanka. Over to you, Dr. Paula.
Thank you so much, Rajiv, and it's an absolute pleasure and honor to be invited to speak to you all. I hope I will tell you something that you don't know already. So I'm going to make a very, well, I was going to say quick presentation. It's not that quick. Let me just share my screen. So I'm going to talk to you, as Rajiv said, a little bit about global maternal, newborn and child health, which I've been working in this space for many years. But first of all, a little bit about myself. So I actually started my career in Sri Lanka. So back in 1986, I had just qualified as a doctor in Ireland. And I went to Sri Lanka on a holiday and I met my husband, future husband at the time. And we ended up going back to live in Sri Lanka in 1989, so many years ago. And we were there for 7 years. We had planned to be there for 2 years, but we ended up being there for 7 years. And this was my favorite car ever, an old 𝗏𝗏𝗏𝗏𝗏, which we bought in Kandy. We lived in Kandy. And we had our first 2 children while we lived in Sri Lanka, and the third one later on. So after 7 years in Sri Lanka, I think I must have gone around the island, I don't know how many dozens of times with friends and visitors and our neighbors, and we had an absolutely amazing time. So that was the start of my career in public health. And I come from Ireland. As Rajiv said, Ireland is, believe it or not, it's actually almost exactly the same size as Sri Lanka. If you superimpose one of these maps on the other, they're pretty much the same size. There's one big difference. Ireland has 7 million people as a population, and Sri Lanka has 22 million people. So you've got a lot more people to deal with than we have in Ireland. So this is an overview of what I'm going to talk about. I'm going to talk about maternal health trends globally, then newborn and child health trends globally. And then I'm going to talk a little bit about stillbirths. As Rajiv mentioned, I'm the chair of the board of the International Stillbirth Alliance, and this is an area that is still struggling to get more visibility. Sri Lanka is doing very well. We're going to talk about that, but many countries are not. And then I'm going to talk about a little bit about the contribution of nutrition to maternal, newborn and child health. And then finally, just some implications for Sri Lanka. And hopefully we'll have time for some Q&A afterwards. So on maternal health, the key report on this is a report that was published by WHO and other UN partners. And it was published in 2023. And it looked at the trends in maternal mortality from 2000 to 2020, so over a 20-year period. And in that time, a lot of progress has been made. In 2020, an estimated 287,000 women died across the world from maternal causes, so equivalent to 800 deaths every day. There has been a good reduction, a 34% reduction in the maternal mortality ratio from 339 per 100,000 live births to 223 in that 20-year period. So from an estimated nearly 500,000 deaths in 2000, we have reduced that quite a bit, but it's still a big burden. And we did make good progress across the world in the beginning of the Millennium Development era, which was from 1990 to 2015. From 2016 to 2020, there's actually been extremely poor improvement, and in many countries are actually going backwards. And of course, we're now in 2025, so a new report will be coming out soon with the latest trends, and we'll be able to see what happened, because we don't yet know the impact of the COVID pandemic and, you know, a rising conflict around the world and climate change impacts. So there are many factors that are telling us most likely things have got even worse. And then when we go to regions, we can see that there are huge regional disparities. So the highest maternal mortality ratios are in sub-Saharan Africa, which has an average rate of 545 deaths per 100,000 live births. And the lowest is in Australia and New Zealand, which is about 4 deaths per 100,000 live births. Sri Lanka's actually doing really well and has been for many decades. Actually, when I went out to Sri Lanka in 1989, I went back to London for a year to do my master's in maternal and child health. And I wrote my thesis about Sri Lanka and why it was doing so well back then in the 80s and 90s compared to many other countries with a similar level of income. And there are many factors about that, which we'll come to. So Sri Lanka's maternal mortality ratio is, in 2020, was around 29 deaths per 100,000 live births, which equals about 89 deaths in a year. So some of you may have experienced, you know, have been in contact with some women who died during pregnancy or birth. But many of you probably haven't, because the numbers are not so high. The countries with the highest MMR in 2020 were South Sudan, with a rate of 1,223, Chad, Nigeria, which also, because of its numbers, accounts for more than a quarter of all maternal deaths globally. And in Asia, only Afghanistan has an MMR over 500. Its MMR is about 620. Your big neighbor, India, has an MMR of 103, which is, you know, they're also making good progress. But it does, because again of the size of the country, this amounts to 24,000 deaths in a year, which is about 8% of global deaths. So this is just a graph to show you, and it's only selected countries. These countries are actually, I'm working with the UK government at the moment, and these are some of the priority countries that the UK government invests in. So you'll see a few of your neighbours there, Nepal, Bangladesh, and Pakistan. Are there from Asia, but the other countries are mostly in Africa. And you can see that there's huge variation. So the blue column is the maternal mortality ratio in 2000, and the orange one is 2020, so 20 years later. So you can see they've all gone down, but some of them have gone down a lot more than others. For example, Sierra Leone's done really well, Nepal has done really well, Bangladesh has done really well, but Nigeria, hardly any, DRC, hardly any, Kenya, hardly any. And this, the right-hand axis is the actual numbers. So, you know, your ratio might be very high, as in South Sudan and Sierra Leone, but their actual numbers of deaths per year are quite low because they have small populations. So the bigger populations are adding more of the burden, and the biggest contributors are, again, Nigeria, DRC, Ethiopia, and Pakistan. And India does fall in there as well. It's not in this graph, but India falls in there. It's in the middle between Nigeria and DRC, again, simply because of the numbers, the vast numbers in India. So what is contributing to this? Well, many factors, as I'm sure you all know very well, but health system failures, poor access to quality maternal care, and a shortage of trained professionals and inadequate resources in the health system. But then you have huge contributions from social determinants, so income inequality, education gaps, and gender disparities. And this is where Sri Lanka has done actually pretty well. Of course, you have some inequality in the country, but it's much less than in some of your neighboring countries and globally. So you've done very well in terms of educating women and ensuring that women have access to health. Sri Lanka with economic problems. I think it's getting back on track. I was in Sri Lanka last November for, we had our annual conference in Sri Lanka, thanks to the College of Community Physicians who hosted it. And it seemed that things were bouncing back again. But if the more fragile your healthcare system, which is impacted by crisis and conflict, the higher generally your MMR is and your maternal health outcomes are worse. And then the impact of HIV/AIDS was a huge factor. Again, that has reduced a lot, and it was more in Africa than in Asia. But it remains a concern in certain areas. And it certainly remains a concern today because, as you know, the US government has pulled the plug on a lot of its funding, and they were funding a lot of HIV treatment in Africa. So that's a massive gap now that countries will have to grapple with. So what are the urgent actions needed? Well, we really need to accelerate progress. I mean, the progress has really stagnated. So if we're going to reach the global target of 70 deaths per 100,000, you can see that some countries have an extremely long way to go. It's going to be impossible, but I mean, we definitely need to accelerate the progress globally. We need to strengthen healthcare systems, increase investments in maternal health services and stillbirth attendance, and we need to address those social and economic inequalities that affect access. And then we need to enhance our data collection and reporting because we often don't monitor very well. Again, Sri Lanka is doing very well here, but many countries are not. So we don't even know how bad the situation is. And we don't know which parts of the country are worse so that you can divert, resources to where they're most needed. So I'm going to move on to newborn health. And again, it is a key report here. I'm just keeping my timer going. There's a key report here from the UN again that came out in 2024, so about a year ago, and that looks at progress again, the latest data around child mortality. And again, global under 5 deaths have dropped to 4.9 million in 2022. It's a 51% reduction from the year 2000, which is amazing. And the under 5 mortality rate declined from 93 deaths per 1,000 live births in 1990 to 37 in 2022. So almost a third, which is amazing. Neonatal mortality, deaths in the first 28 days of life accounted for 47% of under 5 deaths in 2022. And that's up from 41% in 2000. So as under 5 mortality rate reduces, your neonatal mortality rate tends to become a greater proportion of those deaths. And that's an area to pay more attention to when we want to continue to reduce child mortality. So again, regional disparities. Sub-Saharan Africa and Southern Asia bear the greatest brunt. Sub-Saharan Africa accounted for 57% of under 5 deaths, but they only have 30% of the global births. And Southern Asia accounted for 26% of under 5 deaths, 27% of global births. So that's in proportion. Sub-Saharan Africa, less so. A child born in Sub-Saharan Africa is 18 times more likely to die before the age of 5 than one born in Australia or New Zealand. And the highest mortality country with an under 5 mortality rate is 80 times higher than the lowest mortality country. So again, huge disparities. And those disparities continue right down through all the levels. So at global level, regional level, also at country level, of course, you have disparities. And 48% of all global under 5 deaths occur in fragile settings. So where there is conflict, where there is war, where there is huge impact from climate with fragility and floods. We know Pakistan had terrible floods there not so long ago. So although these fragile settings only account for 25% of births, almost double that is where the deaths are. In South Asia, the under 5 mortality rate average is 34 deaths per 1,000, and neonatal deaths, still a major challenge, 22 deaths. So you can see it's much more than 50% of the, it's almost 2/3 of the under 5 mortality rate. And countries like India, Pakistan, and Bangladesh, which have big populations, have made good progress, but they still face significant challenges, as I'm sure you know. So, for example, India has an under 5 mortality rate of 29 per 1,000 live births, which equates to 670,000 deaths in 2022. And that's 14% of all the global deaths. Sri Lanka, on the other hand, a small country, but you have a very good under 5 mortality rate of just 6 per 1,000 live births. Which results in about 2,000 deaths per year with a neonatal mortality rate of 4 per 1,000. So again, you can see it's 2/3 of the under 5, the child mortality rate, which is quite normal where you have lower rates, but that's something to keep on improving, although you're really doing extremely well and you're way better than the global targets. So again, just a graph, to show you a selection again. The yellow line going through is the actual number of deaths, and these are the rates. So the blue one is child mortality, The orange one is infant mortality. And then I've also added in the stillbirth rate just to show you, because that is not actually included in the child mortality data. It's separate. And in many countries, it's not counted. We're going to come to that in a minute. But you can see some countries, again, Somalia, South Sudan, Sierra Leone, have pretty high rates. They have huge reductions. So they really halved their rates, and more so in Sierra Leone from 2020. But they still have quite relatively high mortality rates, but the numbers are lower because their populations, again, are lower. So it shows you have to take both into consideration when you're looking at where to put resources, both globally and regionally. Causes of child mortality, as you know, we've got neonatal causes, which are, as I said, an increasing group within the child mortality, first 28 days of life. Mainly due to preterm birth complications, birth asphyxia, neonatal sepsis and infections, and congenital abnormalities. Congenital abnormalities are a greater proportion in high-income countries, as they have mostly solved the issues with sepsis and many birth complications. But in many countries, the first three are much more important than causes than congenital anomalies. And then you've got postnatal causes, the main causes, of course, pneumonia, diarrhea, malaria, and to a lesser extent, injuries. But important to note, and I'm going to talk a bit about nutrition later, but malnutrition is an underlying cause of 45% of all child deaths. So this is a massive area that we need to look at as a contributing factor. Main challenges here, well, data gaps are a real big challenge. So in these countries, 2 in 5 countries have child mortality data that's more than 5 years. And as you can see, this data is already from 2022, so it's already 3 years old. And many of the countries that are contributing data to that, they're extrapolations from earlier data. So many countries are not very good at keeping up to date. Conflict-affected countries in particular often have very poor or outdated data. So the UN makes estimates based on different sources of data, but it is not always accurate. And then, of course, the COVID-19 pandemic disrupted health systems and data collection significantly. In terms of neonatal mortality, the rate has not declined as quickly as post-neonatal deaths. So more investment is needed in skilled birth attendance, essential newborn care, and postnatal care. So the policy recommendations from this report were, again, strengthening health systems, ensuring universal access to essential newborn and child care, and scaling up vaccination programs, nutrition support, and maternal health services. But then particularly targeted interventions for high-risk groups. And this is probably more relevant for Sri Lanka because you have generally very good data. So you would want to be putting your efforts where the data is not so good, where you have pockets of poor performance or poor outcomes. But globally, we would definitely be prioritizing efforts in sub-Saharan Africa, Southern Asia, and not so much Sri Lanka, but your neighbors like Pakistan, India, and Bangladesh, and conflict-affected regions. And generally, expanding community health work programs is really a good strategy to reach the underserved populations. Again, not such a huge issue in Sri Lanka because you have extremely good reach of your health facilities, but it may be an issue in some places. Data collection is also quite a big issue. Again, Sri Lanka does well, but many countries have quite weak civil registration and vital statistics systems and need to be strengthened. And increasing government investment in monitoring child mortality rates so that we know exactly what the problem is and where the problem is so that we can put resources there. But again, the global targets are really off track in 59 countries. So without very urgent action, a lot of children under 5 are going to die by 2030, 35 million. It's crazy. And 9 million lives could be saved if all the countries would meet the SDG target. So we're talking about a lot of children. So on to stillbirths. Stillbirths has traditionally been a very neglected area. It's quite invisible in maternal and newborn health. Again, Dr. 𝗙𝗢𝗟𝗟𝗢𝗪 in Sri Lanka has done amazing work around stillbirth, and I'm sure many of his colleagues, and I'm sure many of you have. But so Sri Lanka is doing really well in terms of monitoring stillbirths, reporting on them, but many countries are not. So this was another key report released by the UN 𝗦𝗦𝗕𝗦𝗦𝗪 group. That's a combined UN group. In 2020, there was a report on the global burden of stillbirths called 𝗦𝗦𝗕𝗦𝗪𝗦𝗪. These are all live links, by the way. So when we send the presentation around, you'll be able to access all these reports. And then in 2022, there was another report issued in early 2023 called Never Forgotten and the Situation of Stillbirth Around the Globe. But in fact, it is rather still forgotten. But the key message is that stillbirth is common and it's largely preventable. Every 17 seconds, a baby is born stillbirth. It equates to about 1.9 million stillbirths annually. That was in 2022. And this is from 28 weeks of gestation or more. So you have early gestation and late gestation stillbirths. This is only the late gestation stillbirths after 28 weeks because many countries don't count anything before that. So it's difficult to get the global data. In fact, there was a global burden of disease report came out last year, and that looked at countries' data from 22 weeks as well to 28 weeks. And there they came out with a figure of about 3 million stillbirths per year. 2 in 5 stillbirths occur during labour. So that means they could be prevented with better quality maternal health care. Of course, there are some contributing factors that are difficult to address at the last minute, but in many cases, if you have better maternal care and delivery care, you can prevent a lot of these stillbirths from happening. And then, of course, the global 19 pandemic exacerbated the inequalities, so has likely increased stillbirth rates in many places. Again, we have stark inequalities. Sub-Saharan Africa and South Asia account for 3/4 of stillbirths, and half of stillbirths occur in just 6 countries: India, China, Pakistan, Nigeria, DRC, and Ethiopia. So you'll see the same countries coming up again. Again, China's here. It's got very good rates, but it's a huge population. Same with India. The rates aren't so bad, but it's a huge population. So it's contributing a lot to the actual numbers. But a woman in sub-Saharan Africa is 7 times more likely to experience a stillbirth than a woman in Europe or North America. Low-income countries generally have an 8-fold higher increase of stillbirth than high-income nations. And again there, Sri Lanka is doing really well. So the highest stillbirth rate globally is estimated to be around 32, and it's 23 times the lowest, higher than the lowest rate, which is about 4, and that's in only some European and countries and Australia, New Zealand. Sri Lanka's rate is 5.8, so you can see it's really good. It's really close to the lowest. So still, you have about 2,000 stillbirths per year in Sri Lanka. Just in comparison, India has a stillbirth rate of 12.2, which is actually almost at the global target is by 2030 is to reduce the global stillbirth rate to below 12. So India is nearly there, but it amounts to 286,500 per annum deaths, stillbirths per year. So it's a big burden. And again, the graph. So this is just the rates, and just wanted to show you here that. Again, the blue one, the first one is under 5 mortality rate. The second one, the orange one, is infant mortality rate. Then you have neonatal mortality rate in the first month. And then you have stillbirth rates. And generally, your stillbirth rate is almost equivalent to your neonatal mortality. And that's an indication that you're monitoring data, because in the countries with the best data collection and the best outcomes, the stillbirth rate is approximately equal to the neonatal mortality rate. So, and the stillbirth rate there is not included in that higher column in the under 5 mortality rates. It's separate data. It's not included there. So it would be, in terms of all your deaths, it's what contributes from the blue column, the child mortality rate plus the stillbirth rate. So again, slow progress, missed target. Since 2000, the global stillbirth rate has declined by 35%. So similar to other rates. But not as good. So it's been slower than it has been for maternal and child mortality. 56 countries will not meet the Every Newborn Action Plan. This is a UN set target of 12 or fewer stillbirths per 1,000 live births by 2030. They're often underreported. 60 countries lack quality stillbirth data. Not Sri Lanka. Sri Lanka's doing well. Many health systems don't track it properly, so it makes prevention efforts very difficult. But there's also, unlike some of the other deaths, there's a huge stigma and silence around stillbirth. And so many people just don't talk about it. And this leaves families without support and it limits the way how we can do better prevention strategies. So again, urgent action needed. 2.6 million babies could be saved by 2030 if all countries would meet the 𝗦𝗓 reduction target. Key solutions, again, very similar: expanding access to quality antenatal and delivery care, setting clear national targets so that you know what you're going for and you can target your resources, improving stillbirth data collection and classification, and raising awareness and reducing stigma around stillbirth. This makes it a lot easier to deal with the problem, and it also helps parents. There's a huge mental burden on parents from not having adequate emotional support following a stillbirth, and this has a massive impact on their well-being. I've got a couple of slides of data, but I'm going to go through these quite quickly because I do want to get onto nutrition. And I know we don't have so much time, but just to flag again that data quality and availability is really a huge issue. So it's missing in many systems, and there's a lot of misclassification of stillbirths as either neonatal deaths or miscarriages. Some of this is around a blame culture. People in nurses and doctors in the labour wards don't want to report a stillbirth because they feel it reflects badly on their care. So there's often a blaming culture which prevents. We found this was very strong in India. We did a project in India, and it was a huge issue. So we have to start with health workers to help them think through what the benefits are of being clear on the data. It helps them, and it helps your patients. 62 countries have no stillbirth data or very poor quality data, and almost half of countries in sub-Saharan Africa have no stillbirth or quality data. So it's a massive issue. This is just showing you the indicators. I'm not going to go into this, but I mentioned there's early gestation stillbirth, which is from 22 weeks to 28 weeks. And then there's late gestation stillbirth, which is from 28 weeks onwards. This is generally what is used to calculate the data, not the 22 weeks, because many people don't count that. So just understanding what data to collect. Vital status at birth, obviously, the gestational age, the birth weight. These are the standard minimum for a perinatal data set. And so while many of you may not be working in labour wards, but you should be knowing that this information is collected in the labour ward. And then, of course, you want to look at the cause of death, information on the timing of death, to know if it's antepartum or intrapartum, so that a correct medical certificate of cause of death can be provided and the data is recorded and validated. Again, as I said, to a quality assessment, you'd want to be sure that your stillbirth data is relatively accurate. You would expect that it is similar to the neonatal mortality rate. It's usually a portion of around 1. You'd be looking for big discrepancies in that, and then you would think that you're probably missing stillbirths. If the recorded rates are much lower than neonatal mortality, you're probably missing them. And then there are the other factors to look at. So closing the gaps, again, it's improving the knowledge and the understanding of frontline health workers, reviewing the current practice. Again, I'm not going to dwell on this because Sri Lanka is doing very well, but for other countries or maybe some pockets, it's maybe where more action can be strengthened. So again, steps to consider: is stillbirth data currently collated in the HMIS? Are they controlled in a standard way? Are the indicators included at the different tracking mechanisms and dashboards, scorecards? Are you all involved in discussions around stillbirth? Is it being included in medical education, in nurses' education? When there are guidelines and updates from global WHO, for example, are these being passed on to the right health workers? And those are a bunch of resources, all specifically around stillbirth. That's talking to the slides that just preceded this. So you'll be able to look at any of that, anybody who's particularly interested. So I want to move on to nutrition and MNCH, because, as I said, nutrition is a massive burden. In 2022, that's another big report that came out from WHO. There's a link there. And they estimated that 149 million children under 5s were stunted, 45 million children wasted at any given time. But also, on the contrary, 37 million children are overweight or obese. And nearly 50% of adults are overweight or obese, including women who are planning to become pregnant or who are pregnant. This is not just a problem in high-income countries. It's a problem everywhere, and it is growing exponentially. Nearly half of the deaths of children under 5 years are linked to undernutrition, but increasingly we're going to be seeing more and more deaths linked to overnutrition. So it's something really to be aware of and to think about, and I'm sure you're doing that in Sri Lanka. Women, infants, children, and adolescents are at particular risk of malnutrition. Anemia rates in teenagers, for example, are rising globally. I'm not sure what the data is for Sri Lanka. The first 1,000 days from conception to a baby's second birthday are the critical periods for everything, but also for nutrition. And the developmental, economic, social, and medical impacts of this global burden are really huge and long-lasting. So it's a huge impact on our global economy and well-being. But nutrition can be integrated into primary health care. We did a study on this last year, looking at the evidence for the benefit of integrating nutrition into primary health care. And there's a lot of evidence out there. So strengthening and scaling up nutrition service delivery is really effective at reducing stunting, wasting, micronutrient deficiencies, and child deaths. But it also unlocks a whole raft of other benefits. So there are many important effects independent to the effects on the direct nutrition outcomes. But for example, on TB rates, there's a big study that was done, and TB rates improved, and the outcomes improved, as well as other nutrition-specific outcomes when supplements were given. So there is a growing body of evidence pointing to linkages between prenatal and childhood nutrition and other health outcomes. And those are just 2 studies. I won't go into them, but you can look them up if you're interested. As I said, overweight is becoming a huge problem. There is increasing weight in women of reproductive age. And you can see the dark blue, these countries, there are, and again, they are more in high-income countries, but it's growing in many countries. Sri Lanka is a tiny little dot there. I think it's between 20 and 29%, between 20 and 30% in Sri Lanka. It may be between 10 and 19%. But it is a growing problem. So you can see it's growing all over the world, and we need to act. Okay, key messages here are that nutrition investments are highly cost effective. There's a return of $23 for every dollar spent. This comes from a World Bank investment framework, which was released last year. And they have shown that investments to scale up high-impact nutrition interventions could avert 6.2 million deaths in children under 5 and 980,000 stillbirths over the next decade and generate enormous economic benefit. There is a long history of nutrition integration in primary healthcare facilities, but full and effective integration remains quite elusive. But investing in an integrated service delivery rather than as a silo of very nutrition-specific actions is an investment more generally in health and well-being, and really, obviously, well worth the dollars or the rupees spent. And the Universal Health Coverage Agenda offers an opportunity to strengthen nutrition integration at primary healthcare. So we looked at the coverage and access of nutrition services, and we saw that nutrition services frequently lag behind other non-nutrition health interventions, and I'm going to show you a graph in a minute. There was a 2020 study of 5 nutrition interventions in 50 countries, which showed that the coverage of most nutrition interventions falls far below the reach of health services through which they are delivered, particularly for antenatal care and delivery care. So why is this? Well, resource allocation. There's a lot of confusion sometimes around how nutrition services can be integrated, but it's very inefficient to not integrate them. Capacity of health workers is a big issue. The complexity of nutrition programming is very multisectoral, we know that, but so is health. So there are many ways to integrate nutrition. And that means you've got to have a more coherent governance system, which is often lacking in many countries. Multi-sectoral programs are delivered across, obviously, many ministries, and that can be quite complicated. So I'd love to hear what's happening in Sri Lanka. But again, it's a political priority, and it needs us to think and work politically. So I'm sorry, the text is not very clear here, but I'm just going to, basically the dark columns in dark blue are the nutrition interventions, and the lighter ones are non-nutrition interventions. And you can see that there's a gap in all of these areas. The first one is births in a health facility. Not all those births are weighed. The second one is children who receive all their 8 basic vaccinations. Not all of them receive vitamin A. The next one is newborns who are born with a skilled provider, but not all of them are, they're not all getting early breastfeeding. And the last two are particularly worrying. So the second from the bottom is the pregnant women who received 4 or more antenatal care visits. And that's globally, in these 35 countries, that was only 2/3 of women, but only half of them are receiving iron and folic acid tablets, more than 90. So they're not receiving full doses, full treatments of iron and folic acid. And then the last one is children with diarrhea who received oral rehydration. And in these 35 countries, it was less than half of children who received oral rehydration. But of those, only 15% received zinc supplementation, which we know is very beneficial. So there's a huge lag here. There are opportunities there, but we're not delivering these nutrition interventions where we have the contact with people. So nutrition interventions need to be implemented in partnership with the health sector and complement efforts at health system strengthening. Interventions can often be delivered using primary healthcare platforms, supplemented by outreach, community nutrition programs, and child health days. Again, I'd love to hear what you're doing in Sri Lanka. But there is no single global model for good integration of nutrition. It really depends on the country's system and where your opportunities are. But I'm just going to show you a few slides. And again, they're quite heavy, so I'll just skip over them, just show them to you, but you can look at them at your leisure afterwards. And these come from the WHO nutrition framework for universal health coverage, and then the World Bank investment. So this is just showing I'm sure you're all familiar with the building blocks of WHO health system. So the first one is governance and leadership. And it's just, I'm not going to read these all out, but it just shows you where you can act at each level of at each part of the health system to better integrate nutrition. So for example, in governance and leadership, you need to make sure that nutrition is funded within that system, and that the leadership is there, that the policies are there. In terms of the health workforce, of course, they need proper training and education on how to deliver nutrition interventions in their daily work with every contact they have. Health service delivery, again, ensuring that the delivery mechanisms are supporting nutrition integration. Access to medicines and health products, that's where when you're delivering vaccines, you make sure that you are doing growth checks, for example. Financing, making sure that there are adequate resources, and improving the budgeting around nutrition at subnational level. And then finally, the health information systems. We've talked a bit about data, making sure that nutrition data is also collected so that we know where we have gaps. And this is the World Bank investment framework, which was produced last year. And it just gives very clearly, again, I'm not going to read it all out, but it gives very clearly the interventions that can be delivered, how they can be delivered, who's the target group, and what exactly can be delivered. And it goes through prenatal interventions. So we've got antenatal care, we've got iron and folic acid supplementation, calcium supplements, balanced energy protein diet for those who need it, and then malaria prevention in areas where you've got malaria. During perinatal and neonatal interventions, we've got delayed cord clamping and kangaroo mother care, 2 key interventions. And then for under 5 children, we've got vitamin A supplementation, zinc supplementation, therapeutic zinc supplementation for children who are really sick. We've got small quality lipid-based nutrition supplementation, again, for children who are picked up who need special support, or pregnant women. And then micronutrient powders for children for supplement, for fortification. And in areas where you have really a lot of wasted children, acute wasting, you have ready-to-use therapeutic foods. This is a product from UNICEF, but there are other products or locally available products as well to manage acute malnutrition. And then finally, you've got the education and nutrition counselling interventions, so breastfeeding and complementary feeding. So you can look again at all that in your leisure later when you get the presentation. Some resources here are in our website, which we produced guidance a couple of years ago on reaching the most at risk of malnutrition, promoting better nutrition through social assistance, aligning food systems with healthy diets for low-income households, and monitoring and evaluation of nutrition relevant programs with a nutrition indicator database. So if you're ever stuck for an indicator on nutrition, you can look through our databases, lots and lots of examples for different kinds of indicators and where they can be appropriately used. So just very quickly then to finish, some implications for Sri Lanka. So these are, these are general, but maybe more relevant for Sri Lanka. So, of course, you're doing very well in providing good antenatal and delivery care. But maybe there are some rural areas. I think also you've got an excellent cadre of midwives. I'm not sure about community health workers, what's the latest on that, but definitely expanding access to primary health care and making sure that people are getting a really holistic package of services. Will be incredibly important. Then improving emergency care, timely referrals, better equipped facilities and skilled staff. You know, every country struggles, even in high income countries, they struggle with, poor quality facilities, old equipment, out of date, etc. So, trying to improve that wherever you can so that you improve particularly obstetric and newborn emergencies is really critical. And I think for Sri Lanka, that would equate to newborn centres where, you have newborn intensive care, since you're doing very well in the primary healthcare area. On newborn and child survival, we've got, of course, promoting kangaroo mother care, exclusive breastfeeding, and then treating pneumonia, diarrhea, and malnutrition effectively. Using data for better care, so implementing real-time tracking. So, not being one of those countries which has data that is 5 years old. I don't think you are, but, using technology and IT now and AI, artificial intelligence for better use of data is really important because there's so much data there. It's quite hard sometimes to find your way through it and pick out what's important, but AI can really help us here. That's where it can be positive. And then addressing root causes, of course, the malnutrition, poor sanitation, gender barriers. Again, I think it's not such an issue in Sri Lanka, but it could be in some places. So that's it. And that is a picture of the lady who used to help us in our house and look after our children. This is her and her grandchild. She still lives in County, and I'm still in touch with her. So thank you for listening. And I would love to...
Right. Thank you very much, Dr. Paula. That was a very, very interesting lecture. And I think you have given the perspective, the international perspective and where Sri Lanka stands within the global aspect as well, and some areas that as Sri Lanka could develop on, and the use of AI as well. So that was very interesting. So there are a few questions. So let's start off with the first one. So the first one is about as a person who has been in the field for more than 35 years internationally and looking at data from across the globe, how do you see that the global warming and the climate change, has it affected maternal and child health in a global perspective? What do you think? And are we doing enough to address that?
Right. The last bit of your question is easy. We're definitely not doing enough. It's a growing subject, and only in the last, some people have been looking at it for decades, but only in the last couple of years, it's really got increased attention. And WHO is beginning to look at it much more. Of course, they've been looking at it in the past, but it's become such an issue now, and particularly in the last 5 years, I would say, that this is something the global community is looking at very, very much. There's more data coming out now on the impact on maternal and newborn and child health. A lot of it is related to displaced populations. So where you've had floods or conflict, or well, particularly in climate, particularly floods or areas that are just, too hot to live in, people have to move. And with that migration it results in greater vulnerability. So people are displaced. We saw it in Pakistan. Huge parts of the population were displaced with the floods. They have to go and live somewhere. They have to have services. They're hugely, hugely vulnerable. And there's more and more data coming out now, and particularly on, it links to the data where higher numbers are in conflict and crisis affected areas. That crisis bit is often due to climate. So it's often due to the impact of climate and either wildfires or, as we've seen in many high-income countries, but in lower-income countries, it's often you have drought or you have flood or you have both. Ethiopia gets both of them regularly. Every year it gets a drought, and every year it gets in some parts it gets floods. Those people often have to move temporarily or sometimes permanently. Many of them end up in camps. We know that all the data from camps is worse than the average. So it's really growing, and it's going to continue growing. The world is getting hotter. This is just going to become a bigger issue. I know in Sri Lanka, I guess it would mainly affect the coastal areas where water is encroaching. When I first went to Sri Lanka, where I met my husband, it was on 𝗦𝗦𝗕𝗦𝗧𝗦 beach. And those days, in 1986, I tell you, 𝗦𝗦𝗕𝗦𝗧𝗦 was a huge, big beach. We went there, I think maybe 10 years later, it had almost disappeared. So I didn't go in November when I was there, so I don't know how big it is now. But, this is we know that some of the island nations are actually disappearing. Some of the Western Pacific islands are really under threat. So those people have to go somewhere and live somewhere else, and that makes them vulnerable. And it puts a pressure on the receiving countries or parts of the country, which becomes overburdened with additional populations that they can't cope with. And we see it really in Africa, not just the conflict, but also from climate crisis, where people have to move and they end up being in camps for decades, and it has a huge impact on their well-being. So big issue. It's going to get worse. Get prepared.
Right. Okay. Right. So then, with regard to the new political developments in the United States, so with the new political developments, there's a change of policies. What do you think? If you like to, we would like to get a comment from you whether there will be, in a global perspective, with the changes in policies in the United States, will it affect maternal and child health in the future as well, or is there an impact on it?
Yeah, absolutely. Okay, the first thing is that, it's very early days, and we have been bombarded in the last month since President Trump took office with, everything shutting down and USAID shutting down and departments closing everywhere and all the aid stopped. Not only that, they've stopped, at least for the moment, they've stopped funding for the demographic and health surveys, which is generally funded by the US. It's a very expensive thing to do. Many countries can't afford it to do it themselves. All those reports I gave you data from, they come largely from demographic health surveys. If we don't have any more surveys, we're not going to know what the situation is. It's devastating. And then all the HIV treatment that has been stopped. Now, I think we need to just stand back for another month, take a big breath, and see how it all pans out. There's a lot of, crazy stuff going on at the moment. It's very tumultuous. It's very dramatic. We all know that Mr. Trump likes to make a big fanfare. Have to see how it all settles out over the coming months and years. But the indications are not good. The indications are actually really bad. It is very likely that funding to many countries will be hugely reduced, if not completely stopped. And this is in a context where other countries and nations who provide aid are already struggling. The UK government has been struggling for quite a while. I don't know if you know all the politics of the UK coming out of the European Union with Brexit. This had, I'm sure lots of you have links to the UK. This has had a very damaging impact on the UK. Their aid budget, which was at 0.7% of GDP, was reduced to 0.5%, and their economy shrunk. So the total volume of funding going to countries already reduced significantly. I work mainly with the UK government, and my project's very, very small, but other big programs that we were running were shut down because the UK government stopped funding those. So this is going to, of course, it's going to have huge impacts, but it is also a wake-up call for all of us that we need to become more independent. Every country needs to become more independent. Of course, some countries will struggle a lot more than others because they just don't have the economy to support themselves. But we really need to think about how we can use what resources we have better, more efficiently, and try to get out of this dependency. And Europe is very dependent on the US for defense, as you know. We also have to become more independent. So it's a big wake-up call, but it's also, I think, having a very negative effect on that whole global cooperation frameworks and just the whole sort of atmosphere that's out there. It's really, really damaging. It's certainly going to have a massive impact on the health of people in poorer countries. It's going to be devastating, I believe. Yeah, and I don't think we can compensate. So there will probably be a decade of huge challenges coming up ahead till I'd say at least a decade till we really can find ways to come around it.
Well, the future does look a bit bleak there. So, and I think one key point that you told was we have to become independent, more independent that we are. It's high time that we, stop depending on a lot of things.
Absolutely.
And, trying to be independent and look after our own things within our capacity. So that's a very good message that you have given to the healthcare professionals who have joined, a learned audience who is listening in from all parts of Sri Lanka and also globally. We hear that a lot of doctors from abroad are also listening to us, our members.
Fantastic.
So then thank you very much, Dr. Paula, for coming all the way, connecting remotely with us and sharing your knowledge and enlightening us in the field, and with 35 years of experience globally to share the details with us. And we are sure to keep in touch with you as well in the future, and wishing you good luck with all your work in the future as well.
Thank you so much. And really, I mean, as you saw from the data, Sri Lanka is doing amazingly well and has been so for decades. So, I mean, congratulations to you. And that's mainly due to all of you who are the frontline health workers. So a huge thank you to you for all that you do for the population of Sri Lanka. I have such good memories of Sri Lanka. I had such an amazing time there for those 7 years. It was the highlight of our living overseas. After that, we lived in 7 other countries. None was so beautiful as Sri Lanka. It was just amazing. So, so well done.
Thank you very much. We are very flattered.
Thank you for the invitation, Rajiv. It was such a pleasure.
Right. Okay. So that brings to the end of our academic session for this month, and we will see you in a fortnight's time. And we hope and strive that we bring internationally acclaimed international healthcare professionals to share the knowledge with the members of our prestigious organization in the future as well. So hope to see you again in 2 weeks' time. Thank you very much. Have a good day.
Thank you. Bye.